is the outpatient management of CHF. So you come in, we evaluate you, we decide that you're not needing to be admitted necessarily, and that could be a follow-up after this of how we make that decision. But we decide that we're going to send you home. What kind of things can we do from an ER perspective to decrease the likelihood of someone having continued problems?
So outpatient management of CHF is a fairly interesting and somewhat complicated question because it ties into the whole health system in a way. And so it depends on your follow-up. And so one of the reasons why we don't have a functioning CHF pathway in the observation unit is because of the lack of follow-up piece. So if you're in an ideal setting where you can get somebody followed up in 24 to 48 hours and you feel very comfortable that they can go see their doctor, then your management is going to be very different than people that you're going to send out and you know they're not going to have any follow-up in 24 to 48 hours. So somebody comes in, they've got known CHF, they've been off their medicines, right? They big salty meal for Thanksgiving or whatever. You give them some Lasix, they feel better, forget about the BNP, they feel better, they look better, the vital signs are normal, and you send them out. What are the things that could happen to them in 24 to 48 hours that could be bad? Well, you could have made a mistake, and that really wasn't because they ate the salty meal for lunch that caused them to have CHF exacerbation. It could have been because they're having decreasing coronary artery function, and that's leading to more CHF because of decreased EF, those kind of things. So having somebody follow up means that you won't miss those people that are decompensating. All right, so they're in the process of decompensating. You stop that decompensation for a short period of time, but they continue to decompensate down the line. So they don't get to the point where they're really dying before you realize it. The other thing is that you gave them a big bolus of Lasix, and what does Lasix do? It makes you pee out your electrolytes. So you get people that have severe hypokalemia because of the medicine you gave them or because you up their Lasix for the next couple of days, and then they start having problems, all right, because they're hypokalemic, all right? So really it needs to have that follow-up piece to have a successful management of outpatient CHF management. If you have, though, a very knowledgeable patient about CHF that you can do a brief intervention of education on them, you can have very successful outcomes in CHF management, even if you can't have follow-up in 24 to 48 hours. So what do you tell them? Serial weights. If you start seeing your weight go up by a pound, then take some extra Lasix. Here's how much I want you to take. It goes up by 2 or 3 pounds, then I think you need to come back in for to be checked. If you notice that when you're walking, you start getting more short of breath during exercise and things are getting bad, you need to come back. But it's a fairly tricky question, at least from my standpoint, because I think of it as a systems issue. And when you don't have a good system, then it really does open people up for some morbidity if you don't have everything in place to make a safe pathway.
And I agree with everything Matt said. I think that we probably don't put enough people on replacement potassium. Some of the more astute residents are already increasing diuretics that people are going home on, saying, look, you came in because you got volume overloaded on Lasix 20 a day. That's not enough for you. We're going to double your dose. But what a lot of people are missing is, oh, your potassium was either low normal or already low. And you've got to send these people home with replacement of those electrolytes. So watch the magnesium levels. That's one of the reasons I always send a mag level on these folks, is because I know this potassium specter is going to be looming whenever I try to change something later. So always get a mag because you're going to be messing with potassium. Always get a BMP so that you're following that and making sure they're not in renal failure. If they're in acute renal failure and they're short of breath presenting with CHF, that's probably someone that we're admitting anyway. But be very careful because fairly subtle changes. If, oh, look, your creatinine bumped a little bit and now I'm about to double your Lasix, or furosemide. How dare you guys not correct me for using a brand name. So as I double their furosemide, then you're really setting yourself up for failure because the thing that you're trying to do to address this problem isn't going to work because their beans don't work. And so you have to do something that makes sense. I think another thing that people miss a lot is blood pressure control. So if they're really, really hypertensive right now and you're discharging them, that's okay. I'm not one of those people that needs to see 120/60 before they leave, but you should consider, if you've got room for it, upping one of their blood pressure pills when they go home, because that can absolutely make congestive heart failure worse as well. So I believe firmly that we're able to discharge people with blood pressures over 200 systolic safely if they don't have end organ dysfunction, but you probably want to make some sort of change, not just rely. And as Matt pointed out, that follow-up is so important. There are a lot of things about the VA system that are not perfect, But one of the things that they have better than some others is the ability to at least assign you someone to follow up with. And so we're supposed to, every time we see a CHF patient, we're supposed to refer them to the CHF clinic, which is a godsend because those folks do this all the time, and it's going to ensure that they get follow-up at least reasonably quicker than, say, an uninsured patient over here, where in reality it's really hard for them to get out and see anybody in the near future.